Thank you. Thank you, John, for the very kind introduction. It's a pleasure to have an opportunity to present these guidelines here. These are my disclosures. So all of you here know that sexual dysfunction is the most persistent side effect of all prostate cancer treatments, and men suffer from it long into survivorship, as do their partners and the couples in general. We know, too, that culture, sexual orientation, ethnicity, gender identity are all factors that influence how we experience our sexual lives and what kind of rehabilitation we may want to discuss and will be acceptable to us. The guidelines, although initiated by members of SMSNA and ISSM, eventually became a part of Movember's True North initiative to provide maximum support for patients with prostate cancer and their partners in survivorship. These are the first sexual health guidelines in cancer care. So I think we are very pleased that we have spearheaded this initiative, and we hope that this will translate to other guidelines for other cancers. Our methodology followed the route of all guidelines that were developed by the AUA, a rigorous literature review with meta-analysis where necessary and possible, and then we reviewed articles between 1995 and 2022. We reviewed 602 manuscripts, and then the statements were developed by an international multidisciplinary team of experts and patients and partners. We then had an international multidisciplinary team and some patients review the guidelines and incorporated their comments. There are 47 statements in these guidelines in 9 sections, and I will summarize the sections. In some of them, there's just one statement, so you'll actually see how the statement is phrased. It's very much like AUA guidelines in general. And I put in the slides under the summaries sort of the range of evidence and recommendation strengths that were in that section. All the statements generally focus on educating patients and partners. The guidelines are guided by a theoretical model of sexuality, which is seen as a complex experience, incorporating not just function, but also the patient's psychological response, the impact on the partner and the partner's response, and the cultural, social, potentially religious context. The guiding principles, there are 6 of them, begin with the most important one, that clinicians are the ones to initiate conversations with patients about their sexual concerns throughout prostate cancer survivorship. The sexuality and sexual recovery are multidimensional, as I just mentioned. We have learned from research that there is a role for grief and mourning in the process of recovery, and that it enables men and their partners move towards a new paradigm of their sexual relationship despite sexual dysfunction. Men rarely return to baseline sexual function after prostate cancer treatment. Including the partner in sexual health counseling and rehabilitation, if both partners agree, is preferable. And there's a need for a multidisciplinary support for the rehabilitation process. Section 1 speaks to the impact of prostate cancer therapies on the biopsychosocial aspects of sexuality. In summary, again, the clinician is the one to begin the discussion because patients don't always bring up their sexual concerns. Realistic expectations of outcomes and availability of rehabilitation should be addressed. Clinicians should be inclusive, recognize sexual orientation, gender identity, ethnicity, religion, culture as potential influencing factors. And patients should be alerted to the fact that they might be emotionally distressed and that there are therapies that, psychosocial therapies that can mitigate that distress. Section 2, impact of individual prostate cancer therapies on sexual function. So you will all be very familiar with that. Recognizing the side effects of surgery, radiation, hormonal therapy, the difference between recovery or diminution of erectile function based on treatment type, the likelihood of not returning to baseline function, particularly if there's baseline dysfunction already, the likely impact of treatment on sexual function regardless of type of approach to surgical or radiation treatment. And then also delineation of the additional sexual impacts that are not often discussed in clinical care, such as change in penile length and volume, diminution or loss of ejaculate, curvature, orgasmic pain, etc. Also, the impact on fertility is mentioned. Section 3 addresses assessment. It is recommended that patients be screened and assessed, hopefully at baseline and then regularly throughout survivorship. Assessment be tailored to culture, ethnicity, race, sexual orientation, and gender identity. It is recommended that partner sexual function and sexual concern also be addressed because it helps the planning of rehabilitation, and the use of validated measures. Patient-reported outcomes is also recommended, and that is, of course, is a huge gap in terms of international use because, we don't have that available yet. The next section is on lifestyle modification, and that's actually is the statement, optimizing overall and sexual health by reducing and avoiding smoking, engaging in physical activity, and increasing plant-based food versus red and processed meat. So patients are advised that. Psychosexual treatment, again, you need to be familiar with. Oh, not psychosexual, the physical treatment, sorry. It is recommended that individualized sexual rehabilitation and psychosexual support be offered to patients across survivorship, tailored to the prostate cancer therapy, sexual orientation, and partnership, and ethnic and racial context. Grief be normalized as a typical reaction to sexual losses, and recognizing the unique needs of patients who are gay, bisexual, have sex with men, transgender women, and gender non-conforming patients. For patients who don't benefit sufficiently from educational support, they should be referred to sex therapy or more specialized treatment, and referral to online support or groups is recommended where available. Biomedical treatment is what you are all familiar with. Nerve sparing is recommended for everybody regardless of baseline erectile function. Penile rehabilitation is framed as an opportunity to protect the health of the corpora and penile length, and as an activation towards sexual rehabilitation and getting used to sexual pro-erectile aids. Patients are to be informed that this is not a methodology for treating unassisted erectile function. Erectile dysfunction treatments, those recommendations follow AUA recommendations. Patients are offered all erectile function treatments at the same time, and then the treatment is tailored to the patient's interest, goals, and their functioning, and so on. And penile prostheses are offered to patients with persistent erectile dysfunction. Other sexual dysfunctions are addressed, and testosterone therapy is addressed as well, and that is individualized to patients, and risks and benefits are discussed. Lifestyle modifications here address primarily patients on ADT. Patients should be informed about the importance and benefits of exercise for sexual health as a component of their management after ADT. Clinician education is a section that is not always in guidelines like this, but we thought it was important because it is found to be a significant gap. Clinicians often say that they don't counsel patients about sexual health because they don't feel competent to do so, and so education is recommended in an interdisciplinary setting. Healthcare programs and systems are also addressed in these guidelines because this is an international guideline, recognizing that there are different resources, different systems, different attitudinal issues, and even legal issues in healthcare systems. But the main idea is that material and education should be tailored to the local cultural mores and traditions, and that insurance coverage for treatment of sexual dysfunction should be available to all patients, both as a way of providing rehabilitation, but also to equalize access to care, to reduce disparities. The guidelines were published, a summary of the guidelines was published in the Journal of Sexual Medicine in November 2022. The complete guidelines are published on the Movember guideline website, and you can download them. A patient version is now also available and will be soon posted. The guidelines have been endorsed by a number of societies, as you can see here, and we are pursuing further endorsements. And Movember has now committed $750,000 over 3 years to the global dissemination of these guidelines, and efforts are underway to begin implementation in the countries that you see here, but more countries will be included. This is just the beginning of the effort. Thank you very much for your attention.